Hello, everybody. My name is Samir Parikh. I'm a hematologist at the Mayo Clinic in Rochester, Minnesota, and I'm a part of the ex-medical advisory board for the CLL Society. And it is my great pleasure today to speak with Dr. Carsten Niemann. Dr. Niemann, could you please introduce yourself?
Hi, I'm Carsten Niemann. I'm a hematologist from Copenhagen, Denmark, active with past experience also from the National Institutes of Health in Bethesda and also from Brazil. I'm also chairing the Nordic CLL study group focusing on developing clinical trials and data-driven medicine for patients with CLL.
Thank you so much for taking the time to join us today, Dr. Niemann. So the abstract that we would be discussing today was presented at the American Society of Hematology meeting in December 2024. This is abstract number 4609. That title of the abstract is Improved Innate Immune Function upon Preemptive Short-Term Therapy with Acalabrutinib and Venetoclax in patients with newly diagnosed CLL who are at a high risk of developing infections. And this is talking about the translational findings from this PREVENT-ACALL clinical trial. So, Dr. Niemann, this clinical trial is the basis of your research work, particularly in this abstract. Could you please tell us some more about the trial and where things are and how did you come about the findings in this particular abstract?
Sure. So the background for the PREVENT-ACALL trial was actually back in 2014, 2015, where a PhD student in my research group identified an unmet clinical need. Looking at the outcome for patients with CLL from the diagnosis of CLL going forward, he realized that patients who did not meet the criteria for starting treatment still had a high risk of serious infections. And based on the Danish public health data covering a population-based cohort of patients with CLL representing a background population of 6 million people, we could identify that it was more frequent that patients had a severe infection after diagnosis of CLL than actually meeting the criteria to start treatment for CLL. So that was the starting point. We realized we wanted to do something to improve the immune function for these patients. But first, we needed to identify this proportion of patients, 25% having a serious infection within 5 years of diagnosis. And for that, we developed what calls the CLL treatment infection model, a fully data-driven model for pattern recognition, using all the routine data available for patients diagnosed with CLL to identify the subgroup of patients, approximately 20% of patients newly diagnosed with CLL having a high risk of a serious infection or needing CLL treatment within 2 years of diagnosis. And this is what we have built upon. And for the PREVENT-ACALL trial, we are running this analysis for all newly diagnosed patients. It's an investigator-initiated clinical trial running in the Netherlands, Sweden, and Denmark. We have pre-screened more than 450 patients now. We'll continue enrollment until the summer of 2025 and hope to report the clinical results of the trial where we randomize patients between observation and 3 months treatment with Acalabrutinib Venetoclax to improve the infection-free, progression-free survival. Thus, it's both the requirement that the patient stay without progression of CLL, without detectable clinical disease. It's allowed to have minimal residual disease, but we want to make sure you don't have clinical CLL disease and you don't have serious infections. So it's trying to target this immune dysfunction in CLL from a clinical trial perspective using machine learning or pattern recognition data.
Wonderful. So I think if I can paraphrase this a little bit, I think what you and your team have very appropriately recognized is the increased risk of infections that happens in newly diagnosed patients, even if they don't need any CLL-directed treatment right away. And because of the immune dysfunction that accompanies any diagnosis of CLL, I think what you have done in this clinical trial is to try and address the CLL clonal cells, or the cells that are causing the cancerous population, and suppress them by using treatments with acalabrutinib, which is a oral BTK inhibitor that's approved for the treatment of CLL, and with venetoclax that's also approved for the treatment of CLL, with the hope that you can actually suppress the clone completely, and that can improve the immune profile of patients, even if they otherwise don't meet some of the traditional criteria for therapy. So I think that's a very innovative clinical trial. It's a very cool concept. And so, what did you learn from the findings that you presented at the American Society of Hematology meeting last month?
So while we're waiting for the clinical outcome of the trial, we'll have to wait a bit more than a year from now. What we have analyzed here is the companion investigations in translational studies. So we took the blood samples from patients before starting treatment and followed them during these 3 months of treatment with acalabrutinib and venetoclax. And then we had the patients randomized for observation, which would be standard of care. And we followed these blood samples in parallel to see if we could find proxies or immune changes, both in the CLL compartment, obviously that would diminish, but also in releasing the suppression of the other parts of the immune system. And it's inspired by my mentor at the NIH, Adrian Wistner, a well-recognized researcher in clinical and translational in CLL. And he described it as the CLL cells is essentially taking the immune system hostage. So it's the CLL cells suppressing the normal immune function. And that's what we looked for and what we reported here at the ASH meeting, that not only the T cells, which have been studied quite well in CLL, even though it's hard to get exactly how the CLL suppress the T cell function, which is part of the adaptive immune system, making sure you can actually fight virus and bacteria. But here we looked at what's called the innate immune system, essentially the immune system that you have all your life, which protects you against bacterial infections and play a very important role in terms of presenting new microbes if they enter your body to the immune system, making sure that the rest of the immune system can get appropriately activated to fight the infection. And what we could demonstrate here is that the innate immune system is also suppressed by the CLL cells. And while you treat the CLL, suppress the CLL cells by the combination of the BTK inhibitor acalabrutinib and the BCL2 inhibitor venetoclax, it seems that you release the innate immune system and make it more capable of being activated by antigens, by different types of bacteria or virus entering your body and being able to represent that and activate the rest of the immune system. So essentially, indications from the blood samples that this hostage taking of the immune system by the CLL cells is released upon targeted treatment.
That's wonderful. I mean, I think this is of great interest to our CLL patient community, because I think, in parallel with the work that you are showing here, where you can reverse some of the immune deficits, I think a key question that comes to many people's minds is, we've all heard about the lack of an immune response to vaccination in CLL patients, who are receiving some of these drugs, and even in the untreated CLL patient population. So are you looking into seeing if the response to vaccination might be better once patients have received this type of treatment that can improve both the innate immune function and potentially even T cell functions?
So we have not been looking at that specifically upon treatment here, because my concern about how to assess the efficacy of vaccination is that when we measure the serological response, that's essentially how your body produces antibodies upon vaccination, you only capture part of the immune function, because you also need to actually capture the T cell function. And it's been shown by Danish colleagues and international colleagues that even though you don't have a serological response for some CLL patients, half of those without a serological response have a T cell response. So what we do measure in this trial is the number of infections and severity rate of infections for patients in the arm receiving treatment and in the arm observation arm not receiving treatment for CLL to see if we can actually demonstrate a difference from the clinical infections. And at the same time, we are monitoring the changes in the T cell function and the innate immune system, while not testing for vaccinations, because these patients are strongly encouraged in both arms to follow the vaccination program. And we will be able to capture those data in terms of serological response, but I don't think it'll actually capture the full picture. So for me, as I'm treating a lot of patients with CLL, it's much more important to actually capture the clinical outcome in terms of infections. And we have made sure that we capture that both for infections treated at our specialized hematology department, but also on all other hospitals in Denmark for the patients, to be able to get this holistic perspective on the infections burden for patients with CLL.
That's wonderful. And I think that's a critical unmet need in our patient population, because, every time we see a newly diagnosed patient who doesn't meet indications for treatment, we would say, well, we'll see you in 3 months or 6 months. And, patients will routinely ask, what can I do to improve, my ability to fight infections or, decrease the risk of disease progression, etc. I think this is such an innovative clinical trial. So thank you so much for working on it. Any parting thoughts, Dr. Niemann, that you can share about next steps about this particular trial, or in general that you would like to share with the audience?
Maybe one thing as a recommendation for my CLL patients, that yes, you should be aware of the risk of infections, but it should not lead to social isolation. I think also after getting through the COVID pandemic that had specific challenges for patients with CLL, I'm emphasizing for my patients the need to continue your social life, because it also adds to your general health situation. But a lot of my patients actually surprised how much you can do by just regularly washing your hands and using hand sanitizers. And in that way, you can actually keep your social life going, obviously following the recommendations for vaccinations. And then I'm very focused on being available in the public health system of Denmark for our patients to make sure if you have CLL or another hematological malignancy and you face symptoms of infection, you should be able both to reach out to your GP, but also to your hematologist, and get immediate advice on how to actually treat early on the infections if you catch an infection, and obviously be able to manage that going forward together with your hematologist and your DP.
Very well said. I think that is such an important piece of advice for our patients. And so thank you very much, Dr. Niemann, for taking the time to chat with us today, and also for all the excellent work that you and your team are doing. This is such an innovative and a very timely clinical trial, and we are all looking forward to your podium presentation, hopefully in the next year or two at ASH, describing the outcomes of this clinical trial. So again, congratulations on this excellent body of work, and thank you so much for your time.
Thank you so much, Dr. Parikh. It's always a pleasure discussing science and patient care with you.
Thank you.